so our speaker today is Dr. Regina San Pedro, and she is one of our own, she's our own chief resident. For those of you not in medical education, the chief resident is chosen by peers and by the training director it's a leadership position. I can't even list all the things that Dr. San Pedro has helped us with this year. And really your tenure as the chief resident starts 6 months really earlier in setting up all the rotations for the next year. So she's a representative of her peers to the training directors, but then also helps the training directors connect more successfully with her classmates. Dr. San Pedro she's in her 4th year. Almost always the chief resident is a 4th year resident. She's here in our Department of Psychiatry at Texas Tech, El Paso. And she's very glad to be doing her residency here with us in a border town. This has allowed her an opportunity to care for individuals that may identify with or present with multiple health issues. This experience has provided her insight, awareness, and cultural sensitivity in working within our community. She has adopted methods and strategies in conjunction with her education to develop her expertise and her bedside manner. Her eclectic approach allows her to evaluate each patient to effectively treat them. Her attention is on eating disorders as this topic is important to her. Dr. San Pedro was able to successfully treat a female adolescent diagnosed with anorexia nervosa by utilizing her extensive knowledge and experience to formulate a treatment plan that included family-based treatment for anorexia nervosa. And that is as a I don't know, am I killing the punchline? I don't know, but family-based treatment for anorexia nervosa is the only therapy that has been shown consistently to help with anorexia nervosa, one of probably the most difficult eating disorder to treat, or at least the one that's the riskiest for people's health. She's given this presentation a couple times, and then she also allowed me to use her presentation because there was a church, the Seventh-day Adventist church here, asked me to present to them. And that was a great experience too. So thank you for that. So she's our own eating disorder expert, right? And she's one of our own trainees. And Dr. San Pedro is such a pleasure to work with. She is incredibly responsible and conscientious. And I wish she were staying here with us, but I think she is moving to another state. But we wish her all the best, and anyone who has the luck to have her as their doctor is going to be very, very lucky. All right, take it away, Regina.
Oh my goodness, thank you so much, Dr. Martin. That was such a kind introduction. Hi, everybody, welcome. Thank you so much for being with us today to discuss feeding and eating disorders. So I think this is one of the disorders that not a lot of people are familiar with. One, because there's still so much stigma surrounding feeding and eating disorders. So it's really very important for us to identify it, to know how to evaluate, manage, and treat it, okay? All right, so eating disorders affect at least 9% of the population worldwide. So around 28.8 million Americans will have an eating disorder in their lifetime. There is one death every 52 minutes, and about 26% of people with an eating disorder attempt suicide. And that is a significant number. That is one thing that we want to prevent, is for people to die from an eating disorder. So this slide looks busy, but what I want you guys to get from these numbers is, first, eating disorders have the highest mortality rate of any mental illness. So that's important for us to internalize and analyze, okay? And more than 30 million people in the US will suffer from an eating disorder, and out of that 30 million, it impacts around 10 million men. A lot of people think eating disorders affect only women, and that's true. A majority of eating disorders do affect women, but a significant number of men will also face an eating disorder in their lifetime. Over 70% will not seek treatment due to stigma, misperceptions, and lack of education. One thing that was very significant to me from this slide as well is there has been a 119% rate of increase for children under 12 admitted to the hospital for eating disorders. And that's significant, right? Children under 12 should not be bothered so much about how they look, about how they're perceived, about their body weight and shape. Children under 12 should enjoy their childhood, should play, should enjoy being kids. So again, this is why it's very important for us to be educated on eating disorders. Now, there are 6 types of eating disorders. Most of you are probably familiar with the first 3. This one is are more common eating disorders. So we have anorexia nervosa, bulimia nervosa, binge eating disorder, ARFID or avoidant restrictive food intake disorder, rumination disorder, and Pica. So first we go with anorexia nervosa. This was derived from the Greek term from loss of appetite. So there's a general theme in anorexia. The theme is there is a highly disproportionate emphasis placed on thinness as a vital source, and sometimes the only source of self-esteem. They put so much emphasis on their weights, on their shape, and this has become a day-long preoccupation, and it affects the way that their behavior. So meaning they don't eat, okay? There is a drive for thinness or a morbid fear of fatness. There is a self-induced starvation to a significant degree. And because they are not eating, their body is not receiving the appropriate nutrients. So there is the occurrence of the medical signs and symptoms resulting from starvation. We will discuss later on the 2 types, which is the restrictive type and the binge or purge type. So anorexia, the most common age of onset is about 14 to 18 years old. It occurs in about 0.5 to 1% of adolescent girls. It occurs 10 to 20 times more often in females than in males, and is seen in greater frequency among young women in professions that require thinness, like modeling or ballet. So what this slide just wants to tell you is eating disorders in general, especially anorexia, it is very much associated with a lot of psychiatric disorders. They're associated with mood problems, with anxiety, with depression, with obsessive compulsive disorder, sometimes with PTSD. So it's also important for us to analyze, like, is there an underlying mood problem or a psychiatric problem co-occurring with the eating disorder? Because it's very important for us to actually manage those underlying psychiatric conditions. Okay, so there is no one known cause of eating disorders. There's always an interplay between nature and nurture, meaning genetics and environmental factors play a huge role. Okay, so with the biological factors, it has been shown to have a genetic influence. Bulimia, for example, and binge eating, and we'll discuss that later on, they tend to run in families. Eating disorders in general, they tend to run in families. Anorexia nervosa alone actually is 56% determined by genetics. There has been a lot of research with the biological factors like the endogenous opioids, like enkephalins and endorphins. And studies show that these actually contribute as well to the denial of hunger in anorexia. There's also been a lot of studies being done regarding the hypothalamic pituitary axis dysfunction. Studies show that there is evidence for dysfunction in several neurotransmitters like serotonin, dopamine, and norepinephrine. And these are the 3 neurotransmitters that are involved in regular eating behavior. Okay. Of course, social media plays a huge role, especially now. Peer pressure, media, they play a lot in how people, especially the younger generation, perceive themselves. They think that being thin is beautiful. And this is an important issue right now that we need to discuss with kids, with teenagers. Okay, so this is the DSM-5 criteria for eating disorders. There should be, again, an intense fear of gaining weight and becoming obese. This criteria should happen for at least 3 months. So we already discussed this with the initial slide, but these kinds of behaviors should at least happen for 3 months. Now, a lot of people may ask, how do you know, right, if your kid or your child is suffering from anorexia or from an eating disorder? There's been a lot of odd behaviors surrounding patients with eating disorders. A lot of this aberrant behavior directed towards losing weight, most of the time it occurs in secret. A lot of these kids, maybe they don't want to eat with their family, they don't want to eat in public places, and they lose weight by drastically reducing their food intake. So if you notice your child or a peer, a cousin, suddenly not eating, suddenly cutting their food very small, taking very small portions, and there might be a problem. Now, I read this study where it's interesting because, like what I mentioned earlier, anorexia means loss of appetite, right? But they're saying that it's actually sort of a misnomer because loss of appetite is usually rare until late in the disorder. Studies show that these patients with anorexia nervosa are actually constantly thinking about food because they're hungry, because they're not eating. But because of that, persistent drive for thinness and fatness, they want to ignore the hunger. And that's why they do a lot of other activities like running, exercising just to lose weight. They also exhibit a lot of peculiar behavior about food. There are patients who would hide food all over the house, or there are some patients who would frequently carry large quantities of candies in their pockets and their purses. Okay, so these are just some of the behaviors that you can observe with these kids or with these patients. Now, one type of anorexia is the restrictive type. This is where food intake is highly restricted. So these patients, because they want to be thin, they eat fewer than 300 to 500 calories per day and no fat grams. And these are the patients who are also highly overactive. The next one is the binging and purging type. So this is when patients alternate attempts at rigorous dieting with intermittent binge or purge episodes. So they do self-induced vomiting, they use laxatives, they use diuretics or emetics just to get that food out. Now, anorexia affects your whole body. What this is basically telling you is if you don't have enough nutrients in your body, then the organs are going to get affected. Your brains, hair, heart, blood, muscles, kidneys, everything. So definitely a severe anorexia nervosa do have a lot of medical complications. And if not treated, it will end in death. Okay. So lots of times patients will only come to medical attention when their weight loss becomes apparent. Either family members see them as being very thin and start getting worried, or the patients themselves start having problems, like with women. They can have amenorrhea or no menstrual cycle. They can have hypotension, bradycardia. They can have hypothermia or very, very low temperature. So we need to make sure that we look at all these parameters, CBC, we do EKG, electrolytes, glucose, and of course, we check the vital signs. So for CBC with anorexia nervosa, we often see leukopenia with a relative lymphocytosis, especially in those emaciated patients with anorexia nervosa. EKG changes, what are we looking for? We're looking at findings like T-wave flattening, T-wave inversion. The QT interval may be prolonged or lengthened, and there can also be ST segment depression. For electrolytes, if the patient is purging or vomiting, oftentimes we see a finding of hypokalemic alkalosis. And of course, serum glucose is usually low, especially during the emaciated phase. Okay, so this is very important for us to see if the patient is medically stable. The course of anorexia varies greatly. So as you can see here, they can either fall from any of this. There can be spontaneous recovery without treatment. There can be recovery after a variety of treatments. They can follow a fluctuating course of weight gains followed by relapses, or, and this is what we don't want to happen, they can deteriorate and die, right? And that's certainly something that we do not want to happen. Now, what are some of the indicators of a favorable outcome for a patient? One is if they admit that they're hungry, because, admitting that you're hungry means that you're having this insight saying, okay, I'm hungry. And because I'm hungry, I'm going to eat. So definitely one indicator of favorable outcome is admission of hunger. Another is lessening of denial, and of course, improved self-esteem, okay? Management, and we'll go into more detail as we go along. So it can either fall into hospitalization, psychotherapy, or pharmacotherapy. Now, the first consideration in the treatment of patients with anorexia is, of course, to restore the patient's nutritional state. We have to see if they're dehydrated. We have to manage the starvation. We have to correct any electrolyte imbalance, if anything. Now, when do we decide to hospitalize a patient? The decision really to hospitalize a patient is based on the patient's medical condition and the amount of structure needed to ensure patient cooperation. So in general, as per literature, if your patient has a 20% is 20% below their expected weight for height, then they are recommended for inpatient programs. If the patient's weight is 30% below their expected weight, then usually we require psychiatric hospitalization for 2 to 6 months. Okay, and we'll discuss this more in a little bit. So these are the 3 types of psychotherapy that was found to be, effective for anorexia nervosa. For CBT, or cognitive behavioral therapy, this is where patients are taught to monitor their food intake, their feelings, and their emotions. So you teach them to restructure their cognitive thoughts. So there is cognitive restructuring to identify automatic thoughts and to challenge their core beliefs. With dynamic psychotherapy, it's not frequently used, but there has been some studies where it did show some differences. The challenging part with dynamic psychotherapy is oftentimes these patients with anorexia, they do not want to feel invalidated, right? So the important thing is for you to establish a good therapeutic alliance with your patients. You have to convey empathy, and you have to convey to your patients that their autonomy is respected. The last one is family-based therapy, and this is what Dr. Martin was talking about earlier. So family-based therapy is actually really effective in managing patients with anorexia nervosa. So it's called family-based therapy because it involves the entire family, and it actually includes at least one family meal in the office. So this is the type of therapy that Dr. Martin and I actually employed in one of our patients before with anorexia, and it gave us really significant progress. So there are 3 phases, and I'm not going to go into each phase, but in general, what it is you give first the full control to the parent or the guardian. So the parents are in charge of the meals, and they will help the child to reestablish their regular patterns of eating. And then once the child is starting to slowly progress, then you gradually return the control to the adolescent. So this second phase begins once weight of the adolescent is mostly restored. And the last phase, when they're starting to get really, much better, is when you establish the healthy independence. Meaning, if the child is eating, if she or he is not too preoccupied with weight gain, then you start focusing more on other issues of the child, like school, peers, and relationship. Okay, so pharmacotherapy, as of this date, there has been no FDA-approved medication yet for anorexia nervosa. SSRIs have been implicated in managing the symptoms. And the reason why we like to use SSRIs is because they manage the co-occurring disorders that come with anorexia nervosa, most specifically depression and anxiety. There has been 8 small randomized controlled trials, and they evaluated the efficacy of the short-term use of atypical antipsychotics, including olanzapine, risperidone, and amisulpride for the treatment of anorexia. They really did not find any significant increase in BMI, so their first-line use is usually not recommended. So we usually like to use SSRIs. If you combine medications with psychotherapy, that actually gives much better results. TCAs. We don't like to use TCAs in anorexia because there is an increased risk of QT prolongation. Now, 2 SSRIs that have been mostly studied are fluoxetine and citalopram, and it actually mostly shows largely negative results. However, there was one study that found that fluoxetine with a dose of 20 to 60 milligrams was helpful in stabilizing weight-recovered individuals with anorexia nervosa. Just some more medications that I wanted to discuss briefly. They didn't find any good data available for mirtazapine. Lithium, definitely not recommended due to the risk of toxicity. They also looked at prokinetic agents, like the medications that you see here. They may be beneficial in anorexia to reduce postprandial abdominal bloating. And a lot of people, are coming up with dronabinol as possibly a medication, but no RCT data is currently available supporting its use. Okay, now we talk about olanzapine and aripiprazole. So they found that olanzapine can actually increase the appetite, therefore resulting in weight gain. There has been at least 5 clinical trials that showed promising results. However, I was reading one of the researchers who was involved in the study of olanzapine, and she mentioned something really interesting. Like what I mentioned earlier, the issue of the anorexia is that it's not that they're not hungry, right? At the beginning of the disorder, they are hungry, but they just don't want to eat. So the researcher herself was saying, even if the olanzapine increased that feeling of hunger, which really most of them already have, the patients that they studied were very good at not giving in to that feeling. So it really didn't show much promise. Aripiprazole, only case studies are available for aripiprazole, and there has not been any randomized controlled trial yet, as far as I know, that use aripiprazole. But in those case studies, they show that it actually reduced the patient's distress about eating. So that's anorexia. We're now moving on to the next type, which is bulimia nervosa. So bulimia is you have binge eating episodes combined with inappropriate ways of stopping weight gain. After a binge, the individual usually panics. They feel bad because they binged, therefore leading to a secondary attempt like exercising or laxative use to avoid the feared weight gain. A lot of patients with bulimia actually have normal body weight. So what you see here is a binge purge cycle. So they start dieting, right? Because they don't want to gain weight. So they diet. And then something happens. Either they fall into depression, sadness, something stressful happens, like stress eating. So they eat and they eat. So binge eating, as you see here, is triggered. And they start to feel bad. After eating that massive amount of food, they start feeling bad. They start feeling guilty. So they will now purge to avoid weight gain. And they will have that feeling of shame and self-hatred. So they will go back to the strict dieting again. So as you can see, this is a binge purge cycle that we really need to end. Bulimia is more prevalent than anorexia nervosa. It's seen in 1 to 4% of young women. Onset is later in adolescence than that of anorexia. And a lot of them has a history of obesity. Okay, again, nature and nurture, genetics and environmental influence play a huge role. A lot of studies implicated serotonin and norepinephrine with the development of bulimia nervosa. Definitely, there is an increased frequency of bulimia found in first-degree relatives of persons with the disorder. A lot of times, these patients with bulimia are often high achievers. They have a social pressure to be slender, and they describe their parents as neglectful and rejecting. A lot of these patients, according to studies, they are more outgoing, angry. A lot of them are impulsive. And this condition is actually associated with alcohol dependence, with shoplifting, and being emotionally labile, including suicidal attempts. So this is the DSM-5 criteria for bulimia nervosa. Again, it is present when there are episodes of binge eating occurring relatively frequently, about once a week for at least 3 months. There are compensatory behaviors practiced after binge eating, like vomiting, laxative use, diuretics. Weight is not severely lowered, as in anorexia, and they do have that morbid fear of fatness, again, and a relentless drive. Okay, same with anorexia, and really same with all eating disorders. We always need to look at electrolytes, blood levels, vital signs. We need to make sure that your patients are medically stable. Course and prognosis. So there are higher rates of partial and full recovery compared with anorexia nervosa. According to the DSM-5, there's actually about 2% mortality rate per decade. Okay, management is very similar, psychotherapy and pharmacotherapy. So most patients actually with uncomplicated bulimia nervosa, they do not require hospitalization. In general, patients with bulimia, they're not as secretive about their symptoms as those patients with anorexia. Okay, so again, CBT or dynamic psychotherapy. So I'll discuss just CBT because that is the benchmark or the first line treatment for bulimia nervosa. Okay, so with CBT, there is a strict adherence to a rigorously implemented, it's highly detailed, and there's a manual, like it's manual guided treatment. And usually the sessions about 18 to 20 sessions over 5 to 6 months. For pharmacotherapy, so they've studied antidepressants a lot, and they can reduce binge eating and purging independent of the presence of a mood disorder. So there's actually FDA-approved medications for bulimia. There are two. One is Prozac or fluoxetine, as you see here. Another is Vyvanse, which we'll discuss later on. So fluoxetine, they found that 60 milligrams per day of Prozac actually helps a lot. One, it improves the depression, the anxiety, and it improves the eating attitude. And fluvoxamine, not first line, it has a lot of mixed data. Other antidepressants that you guys see here, not recommended, side effect profiles are undesirable. We don't give Wellbutrin or bupropion, avoid the MAOIs. And now with topiramate, there have been 2 randomized controlled trials that demonstrated its efficacy, short-term efficacy, for treatment of bulimia nervosa, and it was found that it improved the binge and purge behaviors. For naltrexone, there has been 4 RCTs which demonstrated mixed results. High doses were associated with significant elevation in hepatic transaminases and should be used cautiously in patients with bulimia nervosa. They also looked at ondansetron. So this is an antiemetic, and they found that it actually reduces the binge purge frequency in one controlled study. Okay, for binge eating disorder. Now, binge eating, recurrent binge eating, where the individual uncontrollably eats an abnormally large amount of food over a short period of time. Unlike bulimia, and this is the difference, patients with binge eating disorder, they do not compensate in any way after a binge episode. It often occurs in private and include foods of dense caloric content. Okay, so who gets binge eating disorder? Again, more women suffer from binge eating disorder. Etiology is largely unknown, but they saw that a lot of patients with binge eating disorders usually have impulsive and extroverted personality styles. They're usually experiencing a high period of stress, and they binge to reduce anxiety or alleviate depressive episodes. So this is the DSM-5 criteria for binge eating disorder. It has 4 features: eating more rapidly than normal to the point of being very, very full, even if you're not hungry. Eating large amounts of food, eating alone, and you're feeling guilty about the episode. These binges must occur at least once a week for at least 3 months, okay? So what is the difference between binge eating and those patients with bulimia nervosa? With binge eating disorder patients, they don't report compensatory behaviors. Now, binge eating disorder versus anorexics, with binge eating disorder is distinct from anorexia in that patients with binge eating disorder, they do not exhibit an excessive drive for thinness. And actually their weight are normally normal or overweight. Course and prognosis, little is known about the course of binge eating disorder, but severe obesity is a long-term effect in over 3% of patients with binge eating disorder. Again, very similar types of management, it's psychotherapy and psychopharmacotherapy. CBT, or cognitive behavioral therapy, is the most effective psychological treatment for binge eating disorder. It was found to decrease binge eatings and the associated problems. And if you combine CBT with exercise, that actually showed much better results than either one alone. Okay, so there are self-help groups. There's a group called Overeaters Anonymous, and they have been proven to be helpful in patients with binge eating disorder. Now, for the treatment of moderate obesity associated with binge eating disorder, there's an organization like Weight Watchers, which can actually be helpful. Pharmacotherapy. Now, Vyvanse. I think I mentioned a while ago Vyvanse with bulimia. I'm so sorry. It's not bulimia. I meant binge eating disorder. So Vyvanse is FDA approved for binge eating disorder. Prozac is FDA approved for bulimia nervosa. Okay. So Vyvanse is FDA approved for binge eating disorder. And they found that it actually decreases the number of binge episodes per week. They also looked at one medication called topiramate or Topamax. They found that it reduced BMI, it reduced the binge eating episodes, and it resulted in greater weight loss in adults. Just be mindful, we do not like to give Topamax or topiramate in those patients with renal impairment. They can cause kidney stones, and it's actually contraindicated with patients with kidney problems. So just keep that in mind. They also studied several medications like antidepressants, specifically sertraline it was shown to have efficacy for the reduction of symptoms of binge eating disorder. A lot of people like to use like orlistat, but data really does not support its efficacy in sustaining binge eating reduction. Now, naloxone, some people have used naloxone, but again, more studies are needed before a general recommendation can be made. Okay, so we're going on to the last three types. This is mostly the less common types of eating disorder. Now it's called ARFID. ARFID, or avoidant restrictive food intake disorder, it's a relatively new diagnosis in DSM-5. It was previously referred to as a selective eating disorder. So with ARFID, the kids or the adolescents, they avoid or restrict food intake. And because they're avoiding or restricting their food intake, there is now a clinically significant failure to meet requirements for nutrition or insufficient energy intake. Okay. Food avoidance or restriction may be based on the sensory characteristics of qualities of food. Food avoidance or restriction may also represent a conditioned negative response associated with food intake following an aversive experience like choking or a traumatic investigation or repeated vomiting. This is more common in children and young adolescents and less common in late adolescence and adulthood. Again, it's associated with a lot of psychiatric comorbidities like anxiety and obsessive compulsive features. People with autism spectrum conditions are actually more likely to develop ARFID, and boys may have a higher risk for ARFID than girls. Etiology, again, it's nature and nurture, genetics, psychological factors, and sociocultural factors are definitely implicated. Anxiety definitely can be a cause of ARFID, especially in those patients who experience anxiety or fear around eating. This is a DSM-5 criteria for ARFID, like what we originally mentioned. Okay, so there are three types with ARFID. It's avoidant, aversive, and restrictive. So avoidant is where individuals only accept a limited diet. It may be secondary to sensory features, sensory aversion, and sensory overstimulation. With the aversive type, the individuals refuse food due to fear-based experiences like choking or nausea, vomiting, pain on swallowing. With restrictive, the patient just does not eat enough and have very small appetites. Okay, ARFID is a serious eating disorder. Definitely, if you're not getting a lot of the nutritional requirement that you need, then you will develop a lot of medical complications like weight loss, growth failure, failure to thrive, nutritional deficiencies. Complications are very similar all throughout with the eating disorders. They can have anemia, electrolyte problems, and cardiac complications, bone problems. So definitely it affects the whole body and the organ systems. Management, very similar. We focus on medical care, behavioral strategies, and pharmacology. First line treatment, very similar. You test and correct mineral or nutrient deficiencies. So make sure that the child is eating a balanced diet, and if needed, we provide adequate vitamins and minerals. The focus of treatment really depends on what factors are causing the eating disorder. So this is important for us to see if there are underlying factors like depression and anxiety surrounding the eating problem. There is no FDA-approved medication for ARFID. They've looked at mirtazapine or lorazepam to decrease anxiety related to eating, but still more studies are needed to make general recommendations. They also used olanzapine. They said that olanzapine may be helpful in reducing the cognitive rigidity in their beliefs about food and to promote weight gain. Again, more trials are needed. Okay, we go to rumination disorder. This is repeated regurgitation of food occurring after eating over a period of at least 1 month. Previously swallowed food that may be partially digested is brought up into the mouth without apparent nausea, involuntary retching, or disgust. The food may be rechewed and then ejected from the mouth or re-swallowed. This is actually rare in both males and females, but it's found to be more common among females. It's more prevalent in those with severe and profound intellectual disability. Studies show that about more than 8% of those with rumination disorder reported daily symptoms, with about 63% reporting monthly symptoms. The exact cause of rumination disorder is unknown. It may be secondary to emotional problems or stressful events. And the most commonly cited environmental factor is actually an abnormal mother-infant relationship. With learning-based theories, it proposed that rumination behaviors actually increase following positive reinforcement, such as the pleasure that the patients experience produced by the rumination. Again, there are like organic factors that we have to look at. There could be a medical problem in the esophagus, gastric disorders. Definitely, it is associated with a lot of psychiatric conditions like depression and anxiety. Okay, we've already mentioned this. This is a DSM-5 criteria for rumination disorder, and the repeated regurgitation should be over a period of at least 1 month. Course and prognosis. Many people with rumination disorder live, healthy lives. It usually doesn't affect the person's daily routines. It's not as debilitating like anorexia nervosa. However, of course, if left untreated, and if the patient is not getting, again, enough nutrients, then a lot of these complications that you see here can occur. Management, very similar, medical care, behavioral strategies. But one thing that's different is actually the surgical care. First, medical care, we need to make sure we correct whatever is abnormal. We correct the caloric insufficiency, we correct nutritional deficiencies, we correct the electrolyte. First line therapy is actually a diaphragmatic breathing with or without feedback. So a child with rumination disorder is actually taught to recognize the signs and the situations where rumination is likely. And then once they start feeling that, they're about to do the act of rumination, then they learn diaphragmatic breathing techniques to use after eating. So this will prevent them from regurgitating their food. So these are the 6 steps to deep breathing. It's a really good exercise that you can do with your patients. Okay, surgical care. So if nothing else has worked, there are a lot of studies on gastroesophageal fundoplication. It has been used as an anti-reflux surgical intervention in cases with a clear physiologic etiology or when the rumination has not responded to less invasive interventions. Okay, last one is Pica. Pica is eating of one or more non-nutritious and non-food substances on a persistent basis over a period of at least 1 month, severe enough to warrant clinical attention. Substances ingested vary with age, and a lot of these things they can eat. Paper, soap, cloth, string, wool. So a lot of, strange things that people usually do not eat. Prevalence is unclear. Among those with intellectual disability, prevalence increases with the severity of the condition. So these are just some of the findings that a lot of studies showed about Pica. Pica was present in about 4% of men and women. 27.8 to 68% of pregnant women experience Pica. It's present in about 18.5% of children, usually present in 10% of children older than age 12. Present in up to 50% of children aged 18 to 36 months. It can be seen in 10% of people with intellectual disability. Okay, there are some certain ethnic populations where Pica is culturally acceptable. So we also need to consider that. So if it is culturally acceptable, then that is not pathologic. A lot of times these kids with Pica usually have a background of very poor family interaction, poor parental supervision. There's maternal neglect. They live in an impoverished structure. Okay, this is again the DSM-5 criteria for Pica that we just mentioned. Onset of Pica can occur in childhood, adolescence, or adulthood. It can occur in otherwise normally developing children, whereas in adults, it appears more likely to occur in the context of intellectual disability or other mental disorders. Again, we need to treat medical complications. Very similar management. First line treatment, again, testing and correcting mineral or nutrient deficiencies. We need to make sure the patient is getting enough nutrition, vitamins, minerals. So we need to replace all those. Definitely behavioral therapies work. We have to educate people with Pica and their families about the condition. We need to create a safe environment for the child where they will not be injured by consuming, the chemicals or other hazardous materials. We need to remove these items from the home so that they won't keep eating it. We need to increase supervision or use distraction to sway the child toward a desirable behavior. There is no FDA-approved medications for Pica. However, there are some studies that show the use of SSRIs, atypical antipsychotics may help with the urges and the impulses. Okay. Again, more studies are needed. All right. I just wanted to end with this last slide because I think it's a very powerful message. Beauty isn't the way you hold yourself. It is how you treat people. The way you love, it's self-acceptance. Beauty is in your soul. Definitely, we need to look at our kids, teach them about good self-esteem and teach them that, self-love is important. It's challenging now because of what media portrays. But that's why we really need to educate a lot of people about this. Okay. Thank you very much for listening. If you guys have any questions, we're open to that.
Thank you so much, Dr. San Pedro. As always, it's a terrific presentation. And you are just such a great speaker. So thank you so much for presenting to us today. There are a couple questions I attempted to answer in the chat if anyone wanted to look at it in writing, but one of them was a complicated one. So let's see, Dr. Richardson, who is a psychologist that actually specializes in eating disorders here in El Paso, if anyone needs to refer, usually people that specialize in eating disorders, it takes a while to get in to see them. She's probably very busy because a lot of people shy away from that because it is because of the mortality, the high mortality rate. I think it's a scary thing to get into. But she asked about labs. How often should we order labs? That's a hard one because it really depends on if the labs are abnormal. A lot of times you will see that the behavior is extremely disordered, but it actually hasn't affected the child or the adolescent's health much yet. So that's best case scenario. And then from that point, I always order a set of labs in the beginning and an EKG, as well as just the regular vital signs, because heart rate is probably the one that's most often abnormal, and in both anorexia and bulimia. And then from there, I make decisions on, depending on what's abnormal or normal, how often to order it again. For example, if let's say that because they are somewhat malnourished, they are anemic, it takes a while to correct an anemia. So you can prescribe iron. You can educate the patient about what type of foods to eat to get up iron. Their iron's higher, because of course iron affects their blood count, their red cell count. So that's one strategy, but it takes a while. So you don't really need to reorder very frequently. But if it's the electrolytes, of course, that are abnormal, sometimes that necessitates a hospitalization and very much more frequent ordering of labs. So that one is a hard one, and it's so dependent on each individual patient. And I've had so many patients where they look pretty, I don't want to say awful, but some of them look very ill, but actually you order their labs and they aren't that bad. I've definitely had that experience. And so then I relax and I don't order the labs as much. I do assess the vital signs every time they come in. And I also, as part of, if we're doing the family-based treatment, then part of that treatment is discussing the weight alone with the patient before you meet with the family. And so we do let the patients know what their vital signs are, what their labs are, what their weight is, and we discuss it and we add it to the therapy. And that is, there are a lot of providers that prefer to not let the child see because they're worried that the child will panic. But really what we're going for with these kids, and usually they're not children, they're adolescents, and anorexia, we're going for them accepting themselves so they can eat a little bit more. And so we do feel it's important to discuss the weight with the patient. But just like everything in psychiatry and medicine and psychology and counseling, we're not computers because we need to connect with the patient and make those decisions. So it's a whole different set of decisions depending on each individual patient and how they're doing. One thing I will say though, as soon as you hear a hint of an eating disorder, get them into a treatment, because a behavioral treatment, even if their health is completely fine. We've done the family-based treatment with many families where the child is not, or the adolescent is not, their BMI is still within the normal range technically. But if they've either lost a lot of weight, they've lost too much weight too quickly, or they're just showing the signs, and they really haven't lost that much weight. But if we don't intervene, then they will end up in a very dangerous place. And with those kids, the treatment is so much more successful because they aren't as deep into this disordered thinking. And working with those kids is so rewarding, because they do get so much better. And their families, and unfortunately their families, the more you can get the family involved, the better it is. And we recommend this treatment, the family-based approach for anorexia nervosa. We recommend that treatment even if it's a young adult, if they're still living in the house with their parents, and there's still a parent-child dynamic where there's a chance that they're going to let their parents help them. And really, it's hard to know if there's a chance. You don't know until you try. And sometimes there are bad outcomes. But if we catch these kids right in the very beginning of the illness, which is really where primary care providers come in, we can definitely have a much better chance of succeeding in all these disorders. Let's see, there was another question. There's a few more now. Let's see. So the lab question, that's a hard one. It depends. But if anything is too abnormal, I always consult with either an adolescent medicine specialist or with a pediatrician. They're usually the most comfortable in making those types of recommendations. And if you can consult with the patient's own doctor, then you have your own multidisciplinary team, even though we don't have a special unit here or a special partial hospitalization program here in El Paso. You guys can make your own teams by working with us, by working with a therapist, a psychologist, and then a medical provider. Let's see, what brief screening questions or tools would you recommend for busy primary care clinicians? Dr. San Pedro, off the top of your head, do you know? There are some. I don't think there's anything that's all that quick, and there's nothing that is, there is nothing that is free, which I'm always looking for free stuff. But we will look into that. Do you know anything, Dr. San Pedro?
Yeah, I mean, I don't think I've used anything really that, as you said, that's free, that's available. But what I usually at least ask my patients is I try to go through the quick DSM-5 criteria and see if they satisfy any of those criteria. One very important question that I like to ask my patients is how they view themselves. Like if they do have that morbid fear of being fat, or if they think that, if they think they're fat, but you can see they're really not, or if they just have that very low sense of self-esteem accompanied by some eating abnormalities, then my index of suspicion would be high. But definitely, I just go through the DSM-5 and try to see.
Yeah, and if you're wanting just one or two questions to ask, I would focus on body image.
Right.
Because if the teenager has a very negative body image, those are the most dangerous situations. A lot of the other stuff, the parents will tell you, like the other eating disorders besides anorexia and bulimia, those ones sometimes are very secret disorders, but you can get at them by comparing, where they are on the BMI scale, what their percentile is, and compare it to what the kid says. So something that would be real common in anorexia, you see a kid who's in the 5th percentile for BMI, and you ask them how they feel about their weight and their body shape, and they're like, oh well, it's okay, but maybe if I lose a few pounds, like something. So those are the most obvious ones to see. A lot of times you'll hear about bulimia from the parents, even though they try to keep it secret because the parents are the ones buying the food. And so they know that their kid has eaten a gallon of ice cream in one night. But bulimia is, a lot of times it's more common in older people, still young adults, but not necessarily a lot of children. But there's definitely some children that are kind of working their way up there when they're still very young. So yeah, if you only had one question or two questions, I would focus it on comparing the BMI to the body image. And the body image, thoughts about body image are going to be much more sensitive and picking up this sort of thing early than the BMI will. We've had a lot of kids whose parents call because they're like, my kid isn't eating. And then when you talk to them, you measure their weight and height, and they're actually definitely still in the normal, but they're already, the thinking is very disordered, and that can be very dangerous. Okay, let's see. The idea with the prevalence of anorexia nervosa and bulimia nervosa is in El Paso. There's some evidence that anorexia and bulimia both are less frequent in Hispanic populations. And of course, El Paso is 85% Hispanic. And so we probably have lower than some other areas in the United States. But that has, in my experience with the kids here in El Paso, as soon as a kid is kind of in the mainstream American culture and they start to think about being thin and being plump is not okay anymore, that is the point at which you're going to start seeing it more. So even in here within the city, maybe overall, if you include people who have immigrated here very, very recently, that group is probably less likely to have anorexia nervosa. But then the ones who are in a higher economic, socioeconomic status and whose families have been here in the United States longer, they probably are more vulnerable to those. Oh, body dysmorphia. A lot of people are talking about that because of all the time we spent, like right now here. I can't see you guys. All I can see is Dr. San Pedro and me. Look at yourself all the time. So people like news reporters and stuff are always asking me about that these days. Body dysmorphia is very, very similar to anorexia nervosa. Don't you think, Dr. San Pedro? It's like the thinking process is almost the same. But the difference is that in anorexia, it is focused solely on the weight. And then body dysmorphia, that can be any part of the body. So a lot of times the disordered or the behaviors you see with body dysmorphia are not, if it's dieting, then it goes into the anorexia category. But it's more on the plastic surgery side that you see with the body dysmorphia. People having multiple plastic surgeries is, the worst case scenario. Let's see. Okay, and we're over time already, and I don't see any more questions. Oh wait, thoughts about treating gastric paresis and anorexia nervosa. Oh my goodness. I can see from the look on Dr. San Pedro's face, she's thinking of the same thing I am. That is a very difficult thing to treat. But they definitely need to include in your multidisciplinary team, include a good GI person. We do have several, the GI department here at Texas Tech. I mean, I don't want to advertise just ourselves, but of course that's who I'm most familiar with. And there is a team here that works with adults, and they do a lot of research also. So hopefully in the future, there will be better treatments that will work for more people, but there is a lot of research in this area. But also the same doctors that are doing the research, they usually also supervise a clinic where those patients can be treated. So at least in the El Paso area, Texas Tech El Paso is somewhere where you might want to have a consultation. And they have both pediatric and adult GI doctors here, but there's I'm sure there's many GI doctors all over the El Paso County region, and then of course people, I know people here from all over Texas. So most big medical centers or cities that are at least 1 million people have plenty of GI specialists, and so I would encourage you to include one of those. But the gastric paresis is a specialty of one of the team of researchers here at Texas Tech, but they are an adult team. Thank you so much. And we got online only like a couple minutes late after all this happened today. So thanks, everyone. Hopefully we'll see you soon.
Take care. Thanks, everyone. Bye.
Bye-bye.